right, now to defend the modern bathroom. The modern indoor bathroom prevents water transmission. Back in the days when we had outhouses, you had fecal material, urine going into holes in the ground. Eventually, that would seep into the water supply. Intestinal bacteria and things like Staphylococcus are remarkably resistant, and then somebody else picks it up later. Although it's better than peeing and pooping directly into your water supply. You have higher numbers then. So, the modern bathroom does prevent water transmission because these types of high numbers of microbe-containing fluids and solids from the human body are taken to the wastewater treatment facility, treated. Most of the microbes are removed before it's put back into the common water supply. Now, to prevent you from getting sick in your own bathroom, though, because you do have a high amount of contact transmission because of the flushing of the toilet, lower the lid. Don't keep your toothbrush out on the counter. Don't keep your razor out on the counter. Just don't even take medications. You know how they have a medicine cabinet in there? Don't keep your medicines in your medicine cabinet. That's the worst place for them. One, you're getting all sorts of microbes where you're going to swallow your medication. Okay. Two, it's moist and it's hot in there every time you take a shower, and that decreases the lifespan of your medication. Put it in your kitchen, but keep it away from kids. Okay. Also, don't get a drink from the bathroom. Just don't do it. So that can cut down on vehicle transmission in the modern bathroom. Also, keep in mind that it's your microbes and you're resistant to them. Your family, you all have the same microbes. You're all resistant to them. But keep in mind when somebody comes home vomiting or with diarrhea, you want to disinfect things very well afterwards. Okay, what are you going to disinfect with? Chlorine-based disinfectants, Lysol spray. Those are your best bets. And replace your toothbrushes. Now for the last one, vector transmission. You gotta love the housefly. You gotta love mosquitoes. Yes, I'm being sarcastic. Vectors are where you have usually arthropods that physically move pathogens around. The housefly is considered a mechanical biological vector, or a mechanical vector, because it's moving. Okay, this housefly has been having lunch on a piece of dog poop and then it flies over and lands on your hamburger to look for dessert. Okay, I hate flies, just in case you're wondering. They physically move pathogens from one source to another. Biological vectors are things like mosquitoes, ticks, fleas, where the pathogen lives part of its lifespan inside of the vector. So when a mosquito bites you, the pathogen has been living for part of its life inside of the mosquito. I hate mosquitoes too. Let's kill them all. Next, we're going to talk about nosocomial infections. We're going to talk about nosocomial infections in general, microorganisms in the hospital, compromised hosts, chain of transmission, and control of nosocomial infections. Alright, let's talk about what a nosocomial infection is. A nosocomial infection is any infection that you get in a healthcare setting. That it can include this emergency room, it can include anywhere in a hospital, doctor's waiting room, a health clinic, anything where you have people coming in for health care. And that includes the medical and the dental. Those are all included. That would also include therapeutic massages, physical therapy situations, and all of that. Now let's talk about the chain of transmission. There are three things that go into a patient getting nosocomial infections. The first one is a compromised host. You've got somebody who's sick. Now this wouldn't necessarily apply to somebody who's just coming in for cleaning or for a well baby checkup. You're less likely to pick up a nosocomial infection in this situation. But in a hospital, after you've just had surgery, you've been in a car accident, you're coming in to get a wisdom tooth extracted, yes, that's surgery, root canals, that's all a surgical situation. Compromised host. Your immune system is dropped because of an injury or a procedure that's going to your body, seem like an injury. Then you have microorganisms in the hospital or clinical environment. When you have a lot of compromised hosts, a lot of people who are sick anyway, they're coming in with infectious diseases, they're bringing in large numbers of them. We're concentrating the microbes. And the third one, the chain of transmission, going from where the microbes are to the compromised host, and you have a nosocomial infection. Now, we can't do anything about the large number of microbes coming in. We can't do anything about the host being compromised. We can prevent the chain of infection. We can lower the numbers of microbes. We can follow good infection control practices to prevent the spread of microbes from host to host. So make sure you follow the infection control procedures wherever you work, if you work in a clinical situation, even if they sound silly. Now, there's nothing that we can do about the number of, or the fact that you're going to have large numbers of microbes in a hospital or clinical environment. You can't do anything about compromised hosts. We're bringing them in there to help them. But we can take out the chain of transmission. We can lower the numbers of microbes in the hospital environment by doing proper disinfection and sterilization techniques. You can protect the host by not moving the microbes from areas of high numbers through to the compromised host. Prevent moving from sick host to sick host. Okay? Breaking the chain of transmission. So make sure that you follow the infection control protocols that you have in any clinical environment that you are working in or visiting, and even if they seem stupid, they're there to break that chain of transmission. So here's a picture showing some of the things that we do to break the chain of transmission. Wearing face shields, wearing masks, wearing gloves. In this situation where they're in the surgical operatory, gowning up, covering hair, all of these things. The instruments that they're using are sterilized. Okay. Now, I also love this picture because there's an oops in it. I can't believe that it made it into a textbook other than to give me the opportunity to say, oh, what's wrong with this picture? We'll give you a few seconds to take a look and see if you can pick it out. Yep, it's the mask on the surge tech, on the assistant nurse. Might not be a surge tech. She needs to tighten up that lower part. She is breathing down into the open wound. I know it's uncomfortable, but you got to wear it the way that the doctor's wearing it, the way that the surgeon is wearing it. Because if you wear masks how they're comfortable, you're not breaking the chain of transmission. Believe me, I've been there, done that. If you follow proper surgical controls, also, it gets really hot when you're gowned up, masked up, double gloved, you name it. But you do it anyway. Also, you want to break the chain of transmission from the patient to the staff, okay, to the folks working in a clinical environment. You're exposed more than the patients coming in and out. The immune system is not lowered, but part of nosocomial infections are those people who work in a clinical environment picking them up. So not only is she breathing down into the surgical site, but this patient may be HIV positive and they are not required to let you know. And you really do not want to pick up HIV. It's fatal. We've got drugs that take care of it now, but it's still a life sentence. So you want to break the chain of transmission to the folks who are working in the clinical environment. All right, let's talk about emerging infectious diseases. These are diseases that are either one, completely new, we haven't seen them before, or two, moving into an area where they haven't been before, or three, it's becoming more prevalent. It used to be a minor rare disease, now everybody's getting it. Now, one of the ways that we get emerging infectious diseases are if we get new strains or serovars. Depends upon whether we're talking about bacteria or whether we're talking about viruses, etc. Okay. Now, in this situation, bird flu would be a prime example. We have a completely new strain that most people are not even partially immune to, and it caused a whole lot of excitement a couple of years ago. Because of the procedures that we have put in place, it turned out to not be that bad. Also turned out that it wasn't as bad as we thought it was, but that's okay. It was good practice for in case we get something else through that's going to be really mean and nasty. Okay, the next one is expansion of resistant microbes and or vectors. MRSA, methicillin-resistant Staphylococcus aureus, is a prime example of this. The microbe Staphylococcus has become resistant to methicillin. Well, we don't give you methicillin until it's become resistant to penicillin, amoxicillin, some of these other antibiotics. Okay, and because of the antibiotic pressure that we're putting on the population, the resistant strains are spreading. It's evolution in action. Okay. If we want to talk about vectors, resistant vectors, for a long time, part of the control of spread of malaria has been to get rid of the mosquitoes. Okay? We were able to eliminate malaria and yellow fever from the United States by killing off all of the mosquitoes that carry those diseases. Unfortunately, we weren't able to kill off all mosquitoes. That's horrible to say from an ecological standpoint, but I don't like mosquitoes. Now, we weren't able to do that in Africa. And now we have mosquitoes that are resistant to the insecticides that we're using against them. And so the malaria itself is not necessarily resistant, but its vector is. We also have malaria that's become resistant to the anti-malarial drugs, so that's part of it too. Spread of people into new areas. Okay, that's one of them. So if we go into a new area that we haven't been before, we're going to be exposed to new microbes. Also, if the microbe or the vector moves to a new area. West Nile virus is a prime example. We had some mosquitoes hitchhike on an airplane from the Middle Eastern area. We're not exactly sure where. Maybe we aren't, I don't remember. But the microbe and the virus took a ride to New York and from there proceeded to spread. The mosquitoes said, "Ooh, check out the new women here," or the new guys, and proceeded to spread in this area, and their little microbes spread within the bird and the human population. Increased human contact, that would be humans having more contact with the vector or the microbe. We think this is partially the case with SARS, severe adult respiratory syndrome, that became a problem a couple of years ago. We think that there was contact with either there's a mammal called a civet, looks kind of like a cross between a cat and a weasel, or with fruit bats. Picked up a microbe that we didn't have contact with the reservoir before, moved it into the human population. Also, failures in public health measures. We can have outbreaks like currently we're having a very sad spread of a rare fungal meningitis. Infection control measures were not followed correctly in the factory. We had spores show up in steroid injections, and now it's spread. And because fungal meningitis grows very slowly, they probably didn't even realize there was a problem until recently, and now it's too late. People have already been injected. Another instance would be is if, say, in the water treatment, okay, if there's been a problem and we don't get a boil order notice out, we can have spread of water by vehicle transmission through water. There's a situation currently down in Utah where they were switching water department precincts, and when they switched, this one city switched from one provider to another, the new provider accidentally had them on irrigation water. Irrigation water is completely untreated, and a fair portion of the people in the town came down with giardia. Yay! That's horrible diarrhea. So that's a failure of public health measures. Now we move on to our last topic, epidemiology. Epidemiology is the study of the cause and spread of different diseases. We're going to talk about descriptive epidemiology, analytical, experimental, case reporting of reportable diseases, and the Centers for Disease Control and Prevention. First, let's talk about descriptive epidemiology. This was introduced by Dr. John Snow in the 1800s in England. In fact, he's called the father of epidemiology. He was a physician in London, and there were frequent outbreaks of cholera in London previous to this. But this one, what he did is he took a map of his area of London and put a dot on there that related to where his patients who had cholera lived. And this is a famous map, and he found that the cases all centered around one water pump. It's called the Broad Street water pump. And so he talked the city fathers into taking the handle off the pump, and the cholera epidemic went away. Somehow or another, cholera had gotten into that particular well. So that's descriptive epidemiology, looking at the cases that you have and trying to relate something between the different cases so that you can describe the spread of the disease itself. Now on to analytical. Florence Nightingale, who also started modern nursing, was the one that did the first analytical epidemiological study. She was working with the hospitals in the Crimean War. That's where the British were fighting in the areas of the Caucasus and the Black Sea area. And what she did is she compared the healthy patients to the sick patients. She was looking at all of the patients and looking at which groups most often got epidemic typhus. And she found that if soldiers were brought in and did not have their clothing removed, i.e. they still had fleas and, lice, typhus is transmitted by human lice, then they were more likely to get typhus, and everybody in the same room with them were more likely to get typhus. She also found that if they had good food, clean environments, they recovered faster even if they did get typhus. So hence modern nursing, modern hospital practices came from Florence Nightingale. Now if you look at this chart that I have here, we're looking at total number of patients receiving the procedure, those that became infected with MRSA. We're trying to crunch the numbers to determine if there is a predisposing factor, say intravenous catheter, or urinary bladder catheter, that would lead to an increased chance of acquiring a MRSA infection. That's the sort of thing that analytical epidemiology looks at. Now on to experimental. With one of my favorite examples, here we've got a picture of a common cold virus. They've done studies where they get volunteers. Since the common cold is not fatal, we can ethically do this, and you can pay volunteers to be infected with a known number or a known titer of virus, and they stay in the facility and we track the progress of the disease. That would be experimental epidemiology. Part of what they do, by the way, is weigh your tissues before and after you blow your nose to measure mucus production. Yay, fun. And I hate to say it, but experimental epidemiology, the volunteers oftentimes are college students. You gotta earn your money some way. Now, we can't do that with fatal diseases. There will never be an experimental epidemiological study involving HIV, but we can do experimental drug studies to see if we can prevent the spread of HIV and also to affect the course of the disease, all of which would be considered experimental. Now on to case reporting. For some diseases that we're interested in studying the epidemiology of them are considered reportable diseases. Right now, the common cold is not a reportable disease. We're not going to report on this. Now, you may get researchers who are interested in it and they're going to do their own data collection. But as far as a nation, there are certain diseases that are reportable. HIV is one, influenza is another, syphilis, whooping cough, pertussis, Actually, whooping cough and pertussis are the same thing. Diphtheria. All of these are reportable diseases. So if in a health clinic or if you go to your doctor and you're found to have one of these reportable diseases, it's reported to the county level. Then the county reports to the state, and the state reports to the nation, which is the CDC, the Centers for Disease Control and Prevention. Okay, so that's how we track diseases. This is how we track how well control measures are working, such as vaccination. In the case of HIV, preventative measures such as condom use, and now we have a drug that we're looking at for preventing the spread. Actually, it's a combination of drugs that have been used previously. All of these are part of the national epidemiological effort. Now, we do have a worldwide organization that tracks diseases called the World Health Organization. That's on a worldwide level. Well, that's it for this chapter. This was probably a far more enjoyable chapter because we're finally getting into stuff that you're interested in, that you've actually had experience with, and you're feeling like it's applicable. But you can see why all of the things that we talked about previous to this goes into the actual application. But feel free once again to listen to this as many times as you want. Remember to ask me if you have any questions about the material.